Good afternoon. I'm honored to stand and have an opportunity to present here again. The purpose of today's presentation is to compare the results of crossbar and parallel bar technique, no disclosures. And when you see a complex, severe, eccentric, or broad type pectus excavatum in the clinic, you can easily think, well, one bar is not enough. Probably I need two bars. Then how to arrange the bars? The parallel positioning is the first one you can think. And this is currently and probably widely used form. Another option is bar crossing in X shape. What is the difference? Always there is something we can learn from the history. The most prominent feature of Gothic architecture is the arches, as you know. And with arches, the ancestors could increase the height of the building, like the left one, and it made the building more beautiful. The left side photograph is an old church located in the outside of the room, and the ceiling is made of serial arches like this. But the ancestors wanted to increase the height more, and they found a solution by crossing the bars like the right side one. This is called as a ribbed vault. And the advantage of this crossing is that they could increase the height of the building more, withstand and transfer the more weight to the thinner walls. And it is quite versatile. You can apply to rectangular or any other shape of the building. You can clearly see the differences between the two buildings. This is me. So our hypothesis is simple. Like the arches in the Gothic architecture, can the crossbar technique could raise the sternum more high compared to the parallel bar technique? So we collected the patients who underwent minimally invasive repair of pectus surgery with two bars. We excluded patients with pectus carinatum or combined type deformity, redo cases, young children, and the patients who needed 3 or more bars or other combined procedures, sandwich procedures, for example. There were 48 people in the crossbar group and 50 patients in the parallel bar group. We measured the anterior-posterior distance between the posterior plate of the sternum and the anterior surface of the vertebral body, and at the level of deepest sternal depression. And both checked in the preoperative and postoperative CT scans. And then we calculated the rate of improvement of the distance after surgery according to this equation. And here's the result. There were no significant differences in the age at the operation or sex or body features or in the proportion of asymmetric excavatum. The crossbar group showed a higher depression index compared to the parallel group, but either eccentricity index or asymmetry index were not that different. The degree of elevation, the calculated rate of improvement was average in 79% in the crossbar group, while in the parallel bar group, 52.7%, which was statistically significant. We also did multivariate analysis. After adjusting with age, sex, and depression index, the results showed here the crossbar technique was the predictor of the degree of elevation, meaning crossbar technique is able to elevate the deep sternum higher than the parallel bar group. However, I want to emphasize that the numbers are small in this study, so this multivariate analysis results can only be a reference for future studies and should be validated. So our research showed the crossbar technique can elevate the sternum more efficiently than the parallel bar group, just like the Gothic ribbed vaults of the ancient churches. However, as I mentioned earlier, the small sample size and retrospective design weakens the power of the evidence. Also, in our study, the classification of the pectus excavatum, the Parkes classification was similar in both groups, but not exactly matched. Thus, the consideration of type distribution, same degree of depression index, is needed for the further study. Also, we measured at only a single parameter, but the other parameters might be beneficial, such as the volume or area of the defect, or measurement in the multiple levels. So in conclusion, in spite of these limitations, our study showed the crossbar technique seemed to elevate a more depressed chest wall than the parallel bar group. Bar crossing is a versatile technique, can handle asymmetric or extreme deformity more efficiently than the parallel bars. Probably, on the contrary, parallel bar seems to be sometimes more effective in the broad flat type, This is just an assumption, though. While crossbar might be more effective in the asymmetric and deeper and lower located depression. We expect further studies in multiple centers might help to give an answer to this question. Thank you very much.